Okay, hey, welcome everybody. We've gone live. Just we this evening we'd be doing a broadcast with Theo, who's doing the connections and conversations, which is always an interesting group. Um, I want to post. I'm going to post the link in a couple of seconds. If you guys could just bear with me, we are broadcasting on on a couple of public channels, and the public channels being the MyRehab Helper Facebook profile, the ARC or the MyRehab Facebook page, and the Duly Diagnosed YouTube channel. We're also broadcasting to the MyRehab Cafe, which is a private and unsearchable Facebook group. MyRehab Cafe is free to any inpatient that's been through the MyRehab or the ARC inpatient program. And if you haven't been through an inpatient program, but you want to participate in the MyRehab Cafe, please go to www.myrehab.com or myrehabcafe.com or .co.za. And you'll find out more information about how you can join the MyRehab Cafe process via that channel. So we're going to be broadcasting on the public channels for 10 to 15 minutes or 20 minutes, depending. Let's see how it goes. And then we're going to switch over to the private and unsearchable Facebook group, as mentioned, the MyRehab Cafe group. So if you want a higher degree of anonymity and or confidentiality, and you're in the MyRehab Cafe group, please wait until we switch over and then click the link and you can jump on. If you're on the public channels and you want to participate and you want to join in on the conversation, please feel free to click on the link. You're welcome to participate. So I think with that, guys, I'm going to bring Theo and Michael into the stream. Hey, guys.
Hey, everyone. How's it going?
Hi, good evening.
How are you doing? Good. So I think let me start. Michael, would you just like to introduce yourself? I know you and Theo are going to have a conversation. I'm going to step aside in a second. But yeah, if you can introduce yourself.
Yeah, sure. My name's Michael Theron. I'm a clinical psychologist based in Umhlanga in Durban. And I have a very special interest in addiction and co-occurring disorders.
Awesome. Cool. Okay, cool. So I'm going to hand it over to you guys if you want to get the conversation going, hey?
Thanks, right. Ryan.
Great.
Cool.
Thanks, Ryan.
Cool.
Great. Welcome everybody to MyRehab Cafe live stream. And I'm very, very excited tonight to have a very special guest, Michael Theron, on board with us. Some of you have gotten to know me over the past couple of weeks, and I'm pretty open and transparent about where my journey has come from. I've had a personal struggle with addiction for many years. And I've been in recovery and clean and sober now, going on almost 13 years. And I must say, I've learned a lot. I've learned a lot from my time in addiction. I've learned a lot from my time in recovery. I've had to unpack a lot. Michael, it's such a privilege to have you on board. You've also played such an important role in my life and my journey, and you've only brought such deep insight and experience and wisdom, and really are a trusted person. Bobby.
Theo, what's going on, brother? How you doing? How's everybody going today?
Yeah, we're good. Thanks, Bobby. Mita, I want to introduce you to Michael.
Michael.
Hi.
Hello, Michael. Nice to see you. Nice to meet you. And I'm looking forward to hearing from you.
Okay.
Yeah, so everybody, tonight we have something very special on the table. We are discussing the topic of the person behind or before the addiction. Hey, Michael, did I get that right?
Well, yeah, the person behind the addiction, I think, is probably a better way to describe it.
Yeah, that's an interesting topic already. That just gets my thinking going. Because oftentimes we, in my recovery, it's when I get when I put my label before my person, then oftentimes that's what my identity becomes wrapped around, is that label, and every single thing or mistake that I do is because I'm an addict. Oh well, it's because I'm an addict, and then it kind of dehumanized. I feel quite dehumanized and discouraged in that process. And what is your take on that?
I mean, the thing is that it is, it's so. Firstly, to be labeled as an addict is yes, there's a lot of stigma attached to it. It can be very dehumanizing, and it's exceptionally reductionist, because now you've been squeezed into this box, which is potentially identified as being very stereotypical. Yes. And then people see you and interact with you on that level.
Yes.
That he's an addict or she's an addict, and so suddenly what happens is that there's no longer a person, there's no longer somebody there to label,
Yes.
And it's something that I feel very, very strongly about, because if we just look at the recovery process, for example, so obviously when somebody's going into treatment for an addiction, that is the presenting problem, and that's what needs to be addressed first and foremost.
Yeah.
However, there's a human being behind that. There's somebody who was once a child, was once an adolescent, was once a teenager. And so there's all of those life experiences that have helped to constitute that person, that individual, that human. And then we throw a label at them and we say, it's because you're an addict. Yes. So now we're taking all of that and we're consolidating it and confining it into a label.
Yes.
And then very often what happens is that it can potentially become a scapegoat, where everything is now blamed on the fact that I'm an addict, or that you're an addict, or whatever the case may be. And yet, when we really get into it, a lot of the reasons why people could potentially relapse are those unresolved issues that have occurred to them through their lives. It's not only when they became an addict that all of this began to happen. Yes, the addiction has slanted the behavior, and there are typical behaviors that we associate with addiction, but it can't be held as the
Michael, I think we're losing you a bit with your internet connection. Okay.
Hey, Bobby.
Hey, Ryan. What's going on, brother?
I love the hat, man.
Well, I had to jump over to my closet and throw it on, because that's what we're talking about here. No more labels, and you know me, I don't like them.
Yeah.
Sorry about that. I'm not sure what happened.
Yeah.
There we go.
All good. All good.
Yeah.
So, Michael, you were saying, yeah? Hi, Chris.
Sorry.
Hey, how are you?
Thanks.
How's it, Chris?
How's it? I'm just going to listen a bit. I don't want to interrupt.
Okay.
Cool.
So, Michael, we started losing you when you were saying that the addiction kind of slants that behavior, and please carry on.
So, in treatment, that behavior should typically be addressed. Okay.
Yes.
But once the person understands it and is has come to grips with it and is able to better manage it, then there's the human behavior which needs to be addressed. And that's where the further deep dive in terms of the recovery process, in my opinion, needs to take place if somebody is to really have a successful recovery.
Yeah.
You know?
Yeah. So I remember, someone coming into treatment that basically had a box full of medication, and probably had with a bunch of diagnoses, this person was clearly struggling in terms of even just managing that quantity of medication. On top of that, there was alcohol abuse and there was illegal substance abuse, along with medication. I mean, where do we even start with the journey of recovery? There's different modalities out there. I mean, sometimes people may say, okay, let's remove the medication, let's see what presents itself, or how does it, what would you recommend would be the way to approach that?
Sure. Thanks, Theo. You've really set me up there. Okay.
Oh, sorry, man. Okay, yeah.
So very quick disclaimer: medication is outside of my scope of practice. Okay. Having worked in the field for as long as I have, look, it's a minefield,
Yes.
and one's got to take into consideration that sometimes the person has not been completely open and honest with the psychiatrist. Okay. And so the psychiatrist is prescribing according to the symptom presentation.
Yes.
And as I said earlier, when you and I were chatting, the problem with the substance abuse and the co-occurring disorders is that very often there can be an overlap in terms of presentation. So that's sometimes where the confusion occurs, because if, hypothetically speaking, if you have not told your psychiatrist, for example, that you are using cocaine, okay, you're going to describe these ups and these downs, this inability to sleep, these racing ideas, and these almost sort of manic type of episodes, and this emotional roller coaster. That could be diagnosed, let's say, for example, as a bipolar mood disorder.
Yes. Yeah.
And I think that often, and I'm not basing this on my assumption. I've had clients, patients, whatever you want to call them, say to me, "Yes, well, we weren't really honest." I was needing sleep medication because I was banging it 3 days a week, and then I would get very depressed during the week. So I thought the psychiatric meds would help. So it really is a landmine, a minefield. So where does it begin? Because also, as we know, for example, with psychosis. Is it substance-induced psychosis? Is it a delusional disorder? Are we looking at a schizophrenia? You know, so very often that's where it becomes very, very murky. And what came first? You know.
Yeah. Yeah.
So yes, there are places which believe that you should take the person off all the medication and see what presents itself. Okay.
Yes.
And for some people that's really necessary.
Yeah.
And that's probably the best way to go. But it's potentially quite risky at the same time. So long as it's properly monitored and properly managed, you know, I don't know. I can't say this is the right way or this is the right way.
Yes.
You know,
Yes.
However, if somebody has had a history of depression prior to the addiction, there's a very strong possibility that they were using substances to self-medicate through the symptoms of the depression, for example. So this is comprehensive, very, very thorough history taking needs to be done. And quite often that isn't done because people are focused on the addiction, you know.
Yes.
So yeah, I don't know if that quite answered your question.
No, definitely, Ryan. I believe that
You're
you're
losing people left, right, and center.
Yeah, Ryan, you had a question.
Yeah. So, you know, I don't want to. I want to sort of just challenge everybody a little bit. You know, Bobby, you aren't keen on the idea of labels, right? Michael, I know from my experience with psychologists generally, I think we're losing Michael again.
Okay.
Have we lost him?
Let me check.
Yeah.
He'll come back. He'll click back on.
There we go.
Okay.
Are you back? I lost you there. So I don't know what's going on.
So I know psychologists generally are loath to use or to share diagnoses with their patients. And I'm going to use DSM terminology because for lack of you know, I'm not up to date with the new stuff, but the Axis 1 and the Axis 2 stuff, and particularly for the Axis 2 stuff, right? The personality stuff in particular, you know, psychologists generally, from what I understand, don't like to share those diagnoses with their patients, or it's just a fact of, you know, they don't like the labels. But do you think that labels can be useful? You know, I know we're talking about stigma that comes with labels and things like that. In AA, and you know, the whole program is structured around you referring to yourself as an alcoholic, and same with NA, obviously. You know, and who, you know, I know obviously the stigma that's attached with certain words. You know, I looked up the word stigma now. So it's a mark of disgrace or infamy, a stain on reproach as on one's reputation. So, you know, do you just, I think a general question, do you think that labels can be useful?
You know, it can very often help to clarify for that person what's been going on. And so, you know, it can be very helpful in terms of helping that person to understand what it is that they're dealing with, and the best course of treatment going forward. You know, so I mean, for example, for the psychiatrists, they can't exactly just prescribe and not disclose to the patients the reasons why
Sure.
they just, why they're doing that. I think where a lot of the hesitancy comes from in terms of the old access to the personality disorders is it takes time to make that assessment, and you really need to be ruling out any other possible reasons for it. So, for example, any of the Axis ones, and it's not something that you necessarily jump into. It's not nearly as easy to diagnose a personality disorder as it is to diagnose a clinical syndrome.
Yeah.
Because the clinical syndrome has a very clear diagnostic criteria, as do the personality disorders. But the personality disorders are a little bit more complex, and I think that's why quite often that diagnosis might come a lot later. Because, for example, you may want to treat the Axis 1 symptoms first and see how the person is responding to what the psychiatrist has prescribed, and then look at the personality patterns that are there.
The thing is though is you see people wearing or owning the fact that they're an addict or an alcoholic and in recovery, and sort of wearing that as a badge of honor almost, right? But if somebody was to be given a diagnosis of, for example, narcissism, which is a word that's thrown around a hell of a lot these days, right? But yeah. You won't see somebody going around, okay, well, I'm in recovery from narcissism, because of there's such a strong stigma, especially these days, with that particular diagnoses or whatever you want to call it.
Yeah. You see, I think the difference is that let's say an alcoholic or an addict, you remove the substance and you put the person is in a recovery program. Whereas when you're talking about the personality disorders, you're talking about a pervasive pattern of behavior. So there isn't a quick fix, and it's not something that can be medicated necessarily. Yeah. So it's a much more intensive, much longer process in terms of interventions and therapy.
Yeah. Bobby, any comments from you, or Theo? Do you want to, or Chris?
Yeah, I'd like to jump in a little bit. I really like I have this no more labels hat on, and when I say no more labels, I don't mean all labels. I'm talking about some specific labels. Me personally, I don't like the words alcoholic, addict, drunk, druggie, and all that other stuff. I don't like the label diseased. I don't like somebody. I think when you're labeled. I like what Mike was saying about being put in a box. The label can put you in a box. Okay, I'm diseased. I don't have the responsibility. I'm going to pass on the responsibility to my caregiver, maybe AA, my therapist, my psychiatrist. For life, I'm going to put myself in a box. I like what else Michael said about. I like to touch base on something like. If a person comes into a therapist or a counselor or whatever, sometimes they're given suggestions, maybe more simplistic suggestions to try, but they don't want to do it because it's not instant gratification. So it's delayed gratification, and it takes a lot of work and effort. So they dismiss that. So they come in and. Right. They don't tell everything. They don't tell everything about their history or life or, well, I was suggested to do this and I didn't do it, So they tell you, or they tell the person what they actually want from the person, you know.
Mm.
And sometimes it's a quick fix, you know, and sometimes it's not. But I agree with Michael. If this is a process, and I don't like labels, you know, everybody knows that, but definitely you have to have some labels. Definitely, yeah, labels can help.
Yeah, well said, Bobby.
Yeah.
Guys, sorry, I want to switch over, if that's okay, to the private group.
Yeah.
If I could ask everybody just to mute their mics for a second. So everybody on the public channels, thank you guys for watching. I think the interesting part of the conversation is going to start happening now in the MyRehab Cafe. So if you're interested in checking that out, go to www.myrehabcafe.com or .co.za. And again, guys, if you're in the MyRehab Cafe and you're watching and you want to jump on, please feel free to do so now. So just give us a couple of seconds.